Portia is the co-chair of that.
The healthcare crisis that brought about the ACA is still ongoing. There's no question. But I think a lot of the discussion now, sort of, especially with a lot of the political discussion going on, focuses on sort of tearing down the statute, stopping the statute, defunding the statute, and the focus becomes about sort of stopping change. I think an important context for all of us to remember before we focus on that is how the arc of change was already happening. And in fact, the Affordable Care Act came along at a crisis point, a crisis we're still enduring in healthcare. We are still seeing a continued steep rise in healthcare costs, with overall healthcare spending rising just in 10 years from 2000, from $1.5 trillion to almost $3 trillion, and it's projected to keep rising. And that's overall costs, but obviously the costs for families are also skyrocketing. The amount of the share that employees are paying for premiums rose from an average of $6,400 in 2000 to $13,000 last year. So it's almost doubled in 10 years, something that's very unaffordable for families, particularly in this tough economy. We continue to see a growing number of uninsured people. I think in the 2008 period, 86 million people were, in 2007 or 8, 86 million people were uninsured for some period during that 2-year period. I mean, that's an astronomical number of people. It's nearly 1 out of 3 non-elderly people in this country. So we really were facing a sort of crisis of coverage, of cost, and as we know, that disproportionately affects members and families of communities of color. I think numbers among the African American community, among the Hispanic community, are in the 40 and 50% ranges for uninsurance in many cases. This trend has obviously been compounded by the recession, and several of you mentioned really wanted to talk a little bit about Medicaid and what the state budgets are going to mean for Medicaid. With the recession and job loss, the numbers of people who are dependent on Medicaid has continued to grow, and in fact, Medicaid enrollment has hit a high of over 50 million last summer, so it's very high. And with the expansions to the ACA, that'll be an interesting dynamic that we look forward to hearing more about. Even those who did have insurance of some kind were facing a series of really predatory practices by insurance companies. You might have insurance, but then you got sick. Maybe you didn't have it anymore. Or maybe you had limits on your coverage that you would run out of care. And patients were paying more and more, but not necessarily for better care. We saw huge problems with hospital-related infections or conflicting diagnoses and competing and contradictory medical instructions. So this was really the context that drove healthcare reform, and I think that's the backdrop against which we have to measure our progress. It would not have been better to do nothing, I guess is where I'm starting from, because the status quo was really untenable.
More features for 2010 that have been implemented. One is funding to expand the number of health providers serving in underserved communities through loan repayment and forgiveness programs. This is really a critical thing. These are once again, the providers, the physicians, the nurses, and other people who are actually providing care in a lot of low-income communities and communities of color. And this is an incentive to get people to support those safety net areas by working there. And the method of doing so is through loan repayment or forgiveness programs. So that has been in effect. Secondly, because as someone mentioned earlier, there's a small business health insurance tax credit to help serve as an incentive for small business owners to provide health insurance to their employees. Thirdly, the third point about insurance coverage for uninsured individuals with pre-existing conditions that was in effect July 1st. And I mentioned a little bit about that before. Okay. Now this, the next page, I'm just going to talk a little bit more about some of the features that I mentioned, like on the first page, and one is the Medicaid expansion. That expansion will cover more low-income people who are currently uninsured. And like I mentioned before, it's a state option right now. Kathleen will tell you more about it later. And that will certainly give more coverage for people to get services earlier. Primary care services, reproductive health services, a lot of services that people were not eligible for. That's really an important one. And another thing that people don't really talk about, because people think more as Medicaid as women are mostly in that program, but once Medicaid expansion takes place, there's health disparities impacting men too. So men who don't have dependent children, but who still fit into the income, the eligibility areas would be able to have Medicaid. So right now it's a state option, but it will be required for states later. Secondly, eliminating the pre-existing conditions, healthcare exclusions. This is really a huge one. People have been excluded from health plans for a number of reasons. I mentioned before, chronic health conditions. People have also been excluded, women have been excluded from health plan coverage because they were pregnant, because they had a previous C-section, because they were a survivor of domestic violence. I mean, so things that don't quite make sense. So having this is a huge reason to give people more access to coverage and care. The last point I wanted to just mention about the dependent care coverage, you're probably asking me, well, Deborah, why do you feel like there's mixed reviews on that? I certainly think it's a good thing to keep kids, well, young adults who were on their parents' health insurance coverage as opposed to them being uninsured. The issue becomes who has the right to that health information? Is it the young adult or is it the parent? Like if you're a young adult and you're getting STI screening and treatment, do you want your parents to know that's what you're doing? That's what you're doing now. If you have that relationship, that's fine. In some families, you would be out of the family if that happened. Do you want your parents to know you're getting contraception? So the privacy issues are the question mark. Is the young adult the one that controls that health information, or is it the parent that actually has the plan? Some of that is going to depend on state health laws too, state health privacy laws. I'm sorry, to solve that issue. That's the question mark on that. As a whole, it's a good thing, but that's something to keep in mind. I just cut myself off again. Okay. 5 minutes. All right, we're gonna fly through 2011. Yeah. The first thing was the establishment of a community first choice option plan for individuals with disabilities. That happens October 1st. States will have the option of offering home and community-based services for people with disabilities through Medicaid, as opposed to having these folks in institutions. So that includes people, there would be an assessment of the individual's particular situation and make a determination made as to whether a community-based program would be better for them or staying at home, and also taking into account what the person wants, as opposed to having them in a nursing home. So that's actually a good plan. Basically, primary care providers would get no less than 100% of the Medicare payment rate in 2013 and 2014 for primary care services. So it kind of brings them up to the same level of folks who accept Medicare. And there's additional funding for the Children's Health Insurance Program. States would get 2 more years of funding for CHIP.
Why health reform could be the most significant social policy issue that we're still facing today. So the Joint Center, we are now 41 years old. The Joint Center historically is focused on African Americans, but now includes other communities of color. Started out as a policy arm of the Congressional Black Caucus, but has spun off to do many different things. In the institute that I direct, the Health Policy Institute, started in 2002, so we're almost 10 years old. But there obviously has been no more historically important period of time than this last couple of years. Our objective in the health reform discussions on the Hill was to center equity in the conversation. The basic issue is this: if your goal is to expand insurance coverage, which almost every politician of every stripe says they want to do, if your goal is to improve the quality of care and to contain healthcare costs, there's no argument about the importance of doing those things. You have to address equity, because those very problems are felt most deeply in communities of color: cost, quality, coverage. People of color are about half of the 50 million uninsured. You probably heard that about 5 times already today. But the reality is that we can't achieve those goals unless one of our key objectives is to not only level the healthcare playing field, but to ensure that everybody has an equal opportunity to enjoy the right to good health. That's currently not the case for many communities of color. It's well documented in the research literature. If you ask the average person on the street, what are the 3 most important issues that you want your elected officials to solve? I know in many African American communities it would be jobs, jobs, jobs. But the jobs piece, in many ways, is dependent on how we address health.
You look at the Affordable Care Act, you'll see that there is a specific section for the territories. And this creates a not double standard, but creates a larger health disparity with Pacific Islanders, Native Hawaiians, and people from the freely associated states living in the territories, not having the same components and access to healthcare resources as their counterparts here on the mainland. And I think these margins, these forgotten stories, these forgotten experiences are things that the Asian Pacific Islander American Health Forum is trying to correct. We continue to work on raising visibility for the communities that we represent. It's often very difficult because we don't all speak the same language, we all don't have the same immigration histories, we don't have the same stories that unify certain other communities of color, and so having that makes it very difficult for us to speak with one voice. One way that we continue to break these barriers down is to build networks in communities across the country. We have a Health Through Action program where we partner with close to 15 community-based organizations in 12 states, typically non-traditional states where you would think that there would be Asian Americans, Native Hawaiians, and Pacific Islanders. We have partners in Mississippi and Louisiana, as well as California and Hawaii. So it's no surprise that in 2010, the US Census found that the Asian Pacific Islander community is one of the fastest growing communities, and I think that there is a lot of potential there for us to move forward and give a voice to an invisible community that many people think doesn't have health disparity problems.
That the rate of diabetes within American Indians, Alaska Natives is outrageous. And so IHS could not provide that service directly to anyone who's accessing their services. They would have to actually contract that piece out to another healthcare delivery system outside of the ITUs to receive that care. So not only did it not help and address the issues of diabetes within tribal communities, but it's also attacking and depleting the funding sources for the ITUs to run. And that is an ongoing issue. And another issue that I do want to mention is that it sounds great, you know, a separate healthcare delivery system that's honoring this trust, responsibility, this and relationship with the federal government is there and it's available. The thing is though that it is on the appropriation side is a discretionary funding. So it's not mandatory to fund this ITU system. It is actually subject to appropriations every year and require tribal advocates, tribes to go to Congress and ask for increased funding. As we know, this country is under a fiscal crisis, and but the Indian health delivery system has always been facing that. And currently, based on other health systems, there's about 50% level of need of funding that's being provided to basic healthcare needs in Indian countries. There are 565 federally recognized tribes. And those are the ones that the federal government recognized, but there are other tribes throughout the country who are not recognized by the federal government, or they're recognized by the state. They're located in 35 states, and what's the really important thing about that is that there's, from the beginning, many of these tribes have had treaties with the federal government, and because of that treaty and because of that relationship with the US government, there is a whole nother system developed from that special trust relationship. And because of that, a lot of the Affordable Care Act and other health provisions really need to include special provisions to incorporate the Indian tribal health, Indian health delivery care system.
And we are growing, and if you don't pay attention to the demographics, it's really gonna catch up to us as we're designing a healthcare reform system. So 2 quick stats just out from the decennial census. The Latinos grew from 35 to 50 million, and we account for 1 in 5 children today, and will account for 1/3 of all children by the year 2030. And so, based on those trends, at least 500,000 Latino youth will turn 18 every year. That says a lot about our electorate. We are a young population today. 1/3 of Latinos are under the age of 18, but we are the future. The second thing that I'll say about this is a lot of people have common misperceptions about the Latino community. And I guess one of my asks is really getting, part of that lies in the fact that people don't understand the demographics. For instance, most people don't realize that 9 out of 10 Latino children are US born. But that's because about half of them come from immigrant-headed households. And so the very implications of what happens to the immigrant community often happens to them. When it comes to Latinos and uninsurance, you've already heard that they are the highest uninsured population in this country. They represent 1 in every 3 uninsured Americans. And then when you get to the immigrant perspective, if you just look at US citizen children in immigrant households, you see a huge disparity of what happens to them. So when we talk about healthcare being the law of the land, there is this community that is underserved today that has great potential of being served in the healthcare reform debate. Getting back to misperceptions, Latinos have the highest workforce participation rate. They're the least likely to receive coverage through the workplace. And so the healthcare reform really provided a new space for them because it established these exchanges as new private coverage options when they could not get into health insurance through their workplace, or they didn't qualify for Medicaid for other reasons. Medicaid and CHIP are also critical programs for the Latino community. Though there are restrictions, and there are pretty serious immigrant restrictions that create lower access, still 1 in 4 Latinos use Medicaid or CHIP for healthcare coverage. As people talked about Medicare and hospital desegregation happened in 1964, and there are different things within the Healthcare Reform Act that help to perpetuate those civil rights, that civil rights legacy. This part of the Affordable Care Act actually removed that exemption, and so regulators and healthcare reform administrators will have to take that and remove that policy since they haven't already done it. What administrative policy is it? Well, it's a letter out. It came out. It first happened under LBJ in the 1960s, and then was reinforced in 1980 through a letter. But basically, it said that Medicare Part B, because doctors weren't receiving direct financial assistance, they had contracts of insurance with Medicare, that they did not have to abide by Title VI of the Civil Rights Act. And so that's also been, and so, Title VI of the Civil Rights Act, that's the part of the act that says that you shall not discriminate against protected classes, including those based on race, national origin, color, and Saxon.
I have like so many questions, and it just seems like.
So
many
that's the
of them
good
are-
part. She likes that she has so many questions that are not going to be answered. So that's
Okay.
good.
And I'm not sure
There is
that-
always something good.
And I'm not sure that everybody knows the answers because so many things are up in the air.
Yeah, for example, the unfunded mandate.
Yes.
Unfunded
Yes.
mandate.
But there's
That's
also,
going to be fun.
Complex. It's a very complex issue.
Miss
I don't
Alice, I'll be
think-
there in a minute.
I don't think over 2 days we can understand everything.